Well, hey there, it's Liz Rohr from Real World NP, and you're watching NP Practice Made Simple, the weekly videos to help save you time, frustration, and help you learn faster so you can take the best care of your patients. Oh my goodness, I am so excited to share this week's video with you. I just can't even describe how excited I am. So in this week's video, I did an interview with a physical therapist. She's actually my personal physical therapist after I had an injury last year, and she's amazing. She is so full of pearls of practice, so full of wisdom, just so smart, and I got to ask her all the questions. So the theme of our interview is, what would you like a primary care provider to know? And I took some questions from the audience. If you're on the email list, you will have the opportunity to submit your own questions for upcoming interviews if you're not already on the list. But we talked about a whole bunch of things: red flags not to miss, when to refer to physical therapy, who would benefit from physical therapy that we might not think about, what to expect, how to counsel patients. Oh my gosh, just so many good things. You know, addressing the topic of access to physical therapy related to funds and all of that stuff. So I really hope you enjoy it. It is so much fun to record. So please let us know what questions you have. I would love to have Stephanie back on. Again, she's just the best. But I hope you enjoy this interview. If you have not grabbed the Ultimate Resource Guide for the new NP, before you check out the rest of this video, head over to realworldnp.com/guide. You'll get these videos sent straight to your inbox every week with notes from me, patient stories, and bonuses that I really just don't share anywhere else, including the opportunity to submit questions to upcoming specialists on the channel. So without further ado, here is our interview. So thank you for being here. Would you like to introduce yourself?
Thank you so much for having me. Hi, everyone. My name is Stephanie Burns. I'm a doctor of physical therapy, and I've been practicing about 10 years. And I mainly work in the orthopedic outpatient setting.
Awesome. I love working with you so much, and you know so much information. So I have so many questions. So we'll jump in. I think to start, I guess to the framing question, what do you see? How would you describe physical therapy? Because I think the context of the situation is that I feel very well versed in physical therapy, especially since working with you personally, learning more and more about what physical therapy is and what it does and all of that. But I think that sometimes the nurse practitioners who are new are not as familiar with physical therapy and what you do. And there are a lot of things to clarify. Maybe to start from there so that they feel more comfortable sending referrals to you and knowing when to refer to you.
Yeah, it's a great question. Honestly, the profession of physical therapy has changed over the years. So it started as a bachelor's, it morphed into a master's, and now there's no schools out there that even have a master's program. You have to have a doctoral degree. And, you know, really what the idea is that we're all movement scientists. And we want to, so once upon a time, you know, PT we really did have a bad reputation. We had a reputation of being people who were helping patients after surgery. That was our main job. And because of that, we pushed a lot of people, you know, we pushed them, and it was painful. And I think a lot of that was just the best evidence-based practice back then, was if you didn't have the range of motion, to push the range of motion, to make the range of motion. And there are some cases where you do have to do that, but they are so minimal. There are very, very few cases where you really have to push through that pain. And the evidence behind that has just changed drastically, and the profession has changed drastically. We don't work under a physician or a nurse practitioner. We work autonomously, and we really have learned how to work best with the patient as an individual. And that means basically that, you know, one size doesn't fit all. So we can't just push everyone and get the same range of motion for everyone and get the same strength for everyone. It's just really important to really hone in on what that individual's goal is and what the practitioner wants us to, you know, what as a team, what we're all trying to achieve from it, and do it in a way that's actually pretty comfortable for the patient. It's not painful. And it's just about optimizing movement.
Yeah. And that's a really great question, because I think that comes up for me a bit, where is physical therapy supposed to hurt? Because I think that I've had some patients come back with various experiences being it was too painful. And then some people saying their physical therapist said to them, I never want you to leave in more pain than when you started. What is the general consensus on that from your perspective? Or does it really patient to patient vary?
Well, it's difficult because pain is difficult to define. So pain comes from each individual's experience with pain. So if you ever notice, like pediatrics, a child's pain is going to seem like the end of the world. And it's because they've never experienced anything before. So everything is just really dramatized. Versus if you work with some of the elderly population, they could have a fracture and be like, I'm fine, no big deal. Now, of course, that's kind of categorizing. Not everyone is like that. But the more experience we have with pain, the less we are afraid of it. And so much of physical therapy, at least in the outpatient world, is learning how to get over the fear of movement. And sometimes there's a psychological pain involved, sometimes there's a trauma involved, sometimes there's, something like abuse, but sometimes it could just be a car accident too. And all of these things create a psychological trauma that really can affect our ability to move and to feel okay. So if we don't feel okay, if we don't feel safe, then our pain is going to be worse. So it's really the physical therapist's job to make you feel like you're in a safe environment and make you really be able to feel like you can communicate. If you can't communicate to your PT that you don't feel comfortable, that this is too much, it shouldn't be the PT saying back to you, well, this is what we have to do, right? They should really be able to hear that and be able to say, okay, like I understand that I'm not physically asking you to do too much, but that doesn't matter because it feels like it's too much for you as the patient. And because of that, we have to back down and we have to say, okay, let's break it down. Let's just do this in steps. Like it's not a big deal if it's too much for you, but the PT has to work with you with that. That's the whole idea of having like individualized treatment for each person out there.
I'm laughing, Stephanie, thinking about us working together. And I did this like really tiny baby move. I had a back injury last year and I did this tiny little baby move. And I was like, so this supposed to hurt this much? And you were like, you were so nice about it. It was just because I was super weak, but it's like you're customizing things and we're like, we're just not going to do that exercise because you're like too scared basically,
Yeah.
And I so appreciate that about you. And I think that sometimes patients will have a frustrating experience where they'll come back and feel like they didn't have that relationship with their physical therapist. So that can be really hard. I think that kind of brings up one thing that you and I have talked about a lot, is about using physical therapy exercise handouts and like what is the difference between physical therapy diagnosis and management versus medicine diagnosis and management, if you want to speak to that.
Yeah.
Basically, I mean, from so I can share from my perspective, nurse practitioners will say things like, oh, you have like a back pain and you have back pain and it's going down your legs. And then so we're like, okay, here's a sheet of exercises and you can go do that. So,
sure.
Yeah.
So back pain's a good one. Another good one is like shoulder, like a rotator cuff injury.
Yeah.
So I think the biggest issue I've seen with it is that there are phases of physical therapy. There's that fear phase, right? You have to kind of like relax the patient. And one thing I just want to touch on is that can be, some of the physical therapy environments that are out there, like people that are treating, more than one patient at a time, like an open gym environment, or just kind of like you don't really feel like you're getting that attention that you need. Make sure that it's a good fit for you. I just want to say that because, really one-to-one physical therapy, one-to-one treatment with any practitioner is really, for me, I think that's the most helpful aspect.
Yeah.
But sorry, back to your other question. With the handouts, like there are phases of healing. And so the first thing is, kind of calming that patient down, reducing some of that pain, get them to really not like tense, protect, and avoid, because that's what they want to do. But in some of the language that we use, encourage, make sure you don't sleep on your stomach, or you don't lift anything over 10 pounds, or you really don't want to lift your child from the ground. That type of language can really encourage fear in our movements.
Yeah.
And instead, it's a little bit, just as much as sometimes we have to sit and breathe with things that are emotionally uncomfortable, we have to kind of sit and breathe and relax and try to move as normal as possible, even when physical things are uncomfortable.
Totally.
So instead of that like tense, protect, and avoid, you kind of want to think of it more of like relax, breathe, and move as normal as possible.
Yeah. Yeah. And then one of the things that you and I talked about, how like with nurse practitioners, the challenge, the more of the challenge for us, it lies in the diagnosis. And then once we get to the diagnosis, our treatments are very algorithmic. So step 1,
Right.
2, 3, and 4. Whereas it sounds like with physical therapy, it's actually quite the opposite.
It's more like psychotherapy in the same sense.
There is a big emotional component, I can attest to it.
There is, but there's also like a problem solving component to it. So kind of like we were talking about those phases. So like that first phase is that relaxation. The next phase for one individual might be to strengthen, and then the third phase may be to stretch. And the problem with some of those handouts is they cover all the phases immediately. And that's where people get a little confused, or maybe not the best, most efficient results from it, because they some work and some don't, and because of that they get frustrated.
Definitely. Yeah. And I found, at least I know in our work, and it sounds like it's been like that for other patients too, is kind of like, if I'm having this pain, my body is very different than somebody else's, and so my quadratus laborum is not doing anything on the left side, compared to like the other muscles, right? And so it sounds like it's also very much like the game is kind of in figuring out the right treatment for that person. Does that sound right to you?
Yeah, like from a diagnosis standpoint, the words of like rotator cuff tear or shoulder impingement or tendinitis, tendinosis, tendinopathy, they all kind of mean the same thing. Like, okay, so before you all hate me for that, what that means is that, yes, of course, from a medical standpoint, something is different happening onto the tissue, right? We understand that. We understand the structure that involved is different. But from a treatment standpoint, it may not change it at all. So one of the biggest take homes that I learned in physical therapy school is we treat the person and we treat the impairment, but we don't treat the diagnosis. So again, like diagnosing something, sure, we know that like if they kind of move like this, they're going to have a rotator cuff issue. Or if they have issues with their back that are very directional preference based, okay, maybe it's more of a disc herniation. But for a treatment, there is no diagnosis equals ABC treatment. And I think a lot of patients want that. Of course, who wouldn't want that, right? The little filing cabinet would go in, here you go, perfect, you're cured.
Totally.
that would be great. And that's where it comes into similar more like psychotherapy than it does with medicine, because there is no like pill that fixes it, right? It's about listening to the patient, about hearing the patient, about understanding their fears of movement, and then really trying to, get to the bottom of it, because there are so many more minutes in the day than just the 30 minutes or 60 minutes you have with the PT. So it's not even so much about doing your exercises. I know I'm going to get a lot of things for that too, but we want you to do your exercises. However, even more importantly than that, we want you to change how you move. Right? So let's go back to that emotional metaphor. If I was struggling with something emotionally and I take 5 minutes or 30 minutes out of my day to meditate, right? It's better than nothing. But what if I just try to like have a mindful attitude throughout my entire day, right? That's going to make a bigger change than just that 30 minutes when I have all these other minutes in the day not being mindful. So that's kind of the same thing with exercise. Yes, that 30 minutes makes us stronger. It's absolutely better than nothing, of course. But throughout the day, and really being mindful of like every time you lift your arm to get dressed or to reach, are you hiking that shoulder? Every time you move your back, are you doing something kind of, and what you're working on and what they're working on are two different things, because they come from two different places and two different compensatory patterns that have been diagnosed.
Right. So I have questions here from our audience. Is there something that often you get like referred to you that's quote unquote referred too late? Like something that would be, you would prefer that they get referred sooner. They could advise patients of when they're making their decision whether or not to go to PT. Like, are there any situations where you see you'd wish they went sooner or that you see that are too late?
Yeah. Anything that's chronic, I would say, is the answer
too
to
late?
that. No. Well, sorry. What I mean by that is a lot of times patients can go to a practitioner and they can say, yeah, I've had this knee pain, but I've had it for 10 years. And in my experience, that's not the person that gets sent to PT.
And they should be.
They should be. Right? So they're the person that's going to be like, oh, let's do a knee replacement. It's been 10 years. But no one's ever asked, did you ever have PT? Because sometimes they hadn't. So when people have surgery before PT, it could be a personal preference where someone just didn't want to go through that. They just wanted to get the surgery first. But there's so much benefit of at least trying it. I recently just had a patient who had a C6, C7 neck herniation, and he couldn't even lay on the table. This guy was in a very, very acute, severe situation, and the referring provider was very much like, you can try PT, but good luck, you're going to need surgery, right? So he really wanted to do a cervical fusion for it. And as we know, you kind of need all of that mobility. When you take a piece of the spine, it doesn't just affect that piece, it affects above and below and kind of all the way down the chain. So we want to avoid that as much as we can, because there really are some downsides to it, especially if you're on the younger side. And this guy came in and definitely was not my easiest patient, but we figured it out and we problem solved, and he's absolutely fine. He has no symptoms.
So cool. That's so
and
cool.
It didn't even take that long. It was probably like 3 months.
Wow.
You know, so
awesome.
It's just always worth the shot, in my opinion. Obviously, I mean, I'm a PT, I'm going to advocate for it, but it's always worth a shot. I mean, what do you have to lose?
Right. Well, I guess I think that's one of my kind of like pet peeves is like this misunderstanding, interdisciplinary misunderstanding, because algorithmically, like I said, like if we have a diagnosis, I've talked about orthopedic hacks in primary care, which is basically like NSAIDs, physical therapy, injections, and surgery. That's the pathway for most orthopedic injuries. I mean,
I agree with that.
Very oversimplified, but like,
yeah,
I think that because like physical therapy is not in our diagnostic, in our toolkit, it's somebody else who's doing it. And so it's like, oh, well, what I can do is refer you for an injection or give you a medicine, right? And I think that because people in the medical, on the medical side, like don't fully understand what physical therapy can do, then it's overpassed, right? And like, I think one of this, like, I just have so many things that I just like want to share, like the things that I've learned from you. I feel like, I don't know, it's like, I just want to like download my brain onto people who are watching. Like, you know, it's like, because I guess like from that example, like so I guess if you can like kind of walk us through, if there's a kind of like, if you can give like a zoomed out perspective of what you would do for a person like that, like it's like, do you know what I mean? How do you boil down what you did for that person so that like to demonstrate how physical therapy helps, right? Like, was it strengthening? Was it mobility? Was it like, I can talk about my situation and what I've learned, but I don't want to, I want you to explain.
Yeah. It's a great question. And this is just a case, right? So it's just one person.
Exactly.
So he responded to, I don't know if you're familiar with like McKenzie-based physical therapy. So McKenzie is a man who was in Australia who came up, it was kind of a funny story. So there was a physical therapy table that was like at an angle versus flat. And he told the patient, oh, you know, go lay down, I'll be with you in a minute. And they were there for back pain, low back pain, and they laid down on their stomach. And they weren't supposed to, they were supposed to lay on their back. But what happened was this patient was better when they got up. And it gave him, I think it was Robin McKenzie, but it gave him an entire new perception of like, wait a minute. So if the disc is protruded posteriorly, what if we move posteriorly to make it glide anteriorly? And that's what we call like directional preference. So in this particular case, with that particular man on the table, he responded well to like extension because we were gliding the disc more anteriorly by moving posteriorly. And you get some people, it's a little bit less common to have someone with an anteriorly translated disc, but sometimes like gymnasts or skaters or dancers, people who go into extension a lot will have that, and then they're going to respond to flexion. Or another group that tends to respond to flexion would be more your people with like spinal stenosis, because they need the canal to be open. And so we're going to get more of that opening with flexion. One of the things that can be deceiving, which is kind of ties back to that handout question you had, is that when you see back pain, a lot of times on that handout is flexion. Go into a ball, bring your knees to your chest, right? So why does that help? It does help. But only temporarily, and actually can, not all the time, but can do more damage. Right. So if you're going anteriorly, right, you're going to open up that vertebral space, and you're going to allow that disc and that nerve to breathe. However, it's also going to, because it has more space now, it's going to slide out in that direction. So when you close it back down, now the disc is living more so out here and pinching on that nerve even more, right? So if we close it down, ow, that hurts, right? It's uncomfortable, it's painful. So immediately we think, oh, don't do it. Kind of, right? Maybe don't do it with so much load or so much gravity. What if we did it in like a gravity minimized position, like that guy on the table? And then so ending up, kind of bringing yourself backwards. And then so now your vertebral space is going this way, and you're kind of pushing that disc back into place. And now it's more centered. And what you have to do now is you have to stabilize it to stay there. So the ligaments around here, they've been kind of stretched out because things aren't in the position. The muscles are probably a little atrophied. That's probably how you got there in the first place. And then you have to get it to stay there. But if you try to stabilize it there the whole time without putting the disc back into place, that's like not really going to be effective.
Totally. So it's like a combination of assessing what the issue is, whether it's spine or shoulder, and like identifying what is too loose and what is not strong enough and what is like tight. And I think like one pearl, I feel like I have to gush it out. It's one of the things you talked about with me was like, people talk about, I think I see these things on like pop health things everywhere too, of like stretch this muscle every day, right? And it's like, this muscle is always tight in people. But do you want to talk about like what muscle tightness is? I know we have some other like referral related questions, but what would you say to somebody who's like, oh, my back is always so tight, I just need to stretch it?
Yeah, well, let me just wrap up that previous question. Sure. So because the guy was a neck patient, I didn't answer any questions about that. But there are also directional preferences for the neck. And a big one is kind of posture, because when we tend to sit, we kind of do this, right? So our neck gets really forward, and then that's how we screw. You're laughing because I've told you about this.
I know.
You're like, I'm going to sit up closer.
I promise I do my exercises.
But if you kind of tuck that chin in, you pull it back, it's not about squishing, right? Because you can hear that in my voice. It kind of, it's also awkward. You can feel it's all crushed. But if you elongate, like you have a string in the back of your head and you're kind of being pulled up and back, that opens up some space, also pushes that disc back in. So we did a lot of different variations of that for him. We kind of tucked the chin, because the first one didn't work. We did a little bit of like a lateral component, because he had a lateral component with the disc. We kind of tucked the chin and did the chin tuck, because that created a little bit of different force that was very helpful for him. And then we just progressed it. So you kind of find, the biggest thing is find the thing that works. And if you can't, ask someone else, because there is something that does work.
Yeah. And like how beautiful of an example to share with people, because like to see behind the scenes of what actually happens in physical therapy, to know that like you can help somebody with that severe problem through movement alone. I mean, the person has to come to appointments, they have to participate, right? They have to sustain the things that you practice together, but that is so impactful.
And he was a great patient. He was super on top of everything we talked about. So it really does make a big difference when you kind of implement everything that we ask you to.
Yeah, totally. Totally. But yeah, do you want to share, I guess, like about muscle tightness?
Oh, yeah. So I think one of the biggest misconceptions that can be out there is what is tightness?
Mm-hmm.
So let's take a runner. That's a pretty standard example. So an IT band, right? Everyone gets like a tight IT band. So IT band, kind of that lateral aspect of your leg from your hip down to your knee, right? So if you're running and this tightens up, people are like, oh, I foam roll it.
Mm-hmm.
Sure, great, that makes sense. It's going to release it. But my question is, well, why does it get tight?
Mm-hmm.
You know, what are we missing? Because if you keep running and it gets tight, and then you keep foam rolling and then it gets loose, and then you keep running, it gets tight, and you keep foam rolling, it gets loose, what are you really solving?
Mm-hmm.
It's just, I mean, people kind of do that. They're like, oh, well, this is just what I have to do. It's like, well, is it?
They think
Is
it's
it?
like their body is like, oh, my body is just this way.
Yep, they absolutely do.
Mm-hmm.
And it's you got to go beyond that. You really have to go beyond that. And again, if you don't have a PT that doesn't go beyond that, find a new one, because that's not great practice. You don't want to just be chasing symptoms. Mm-hmm. You always really want to be getting to the root of the cause. Mm-hmm. So this is a little bit of a blanket statement. It's not true for everyone, but sometimes with runners, what actually is the issue is a weak glute med. So our glute med is also on the lateral aspect of our hip, and glute med tends to get pretty atrophied, and not even so much that it doesn't exist in a strength way, but we don't tend to have that neural connection to it anymore. We lose that neuroplasticity. Mm-hmm. So it takes a little bit of time to turn back on. It kind of went it's like a muscle that went to sleep. It's dormant. Yeah. So we can wake it back up, and that's great. But that's what people don't realize is, oh, well, if I just do this exercise, it'll wake back up. Maybe. But if you're not taught how to do that exercise, you're not taught where you should feel it. You're not asking yourself, what is the intention of this exercise and where should I feel it? You're probably not getting that result. In fact, you may still be using your IT band because that glute med has shut off, right? That has a responsibility in the body. So if it's not working, something else has to absorb its job, right? So we have this force that the glute med is supposed to absorb and supposed to distribute, and it's not doing it. So who is going to do it? And this is why I said that's a little bit of a blanket term, because that may not be IT band for some people. That may be low back. That may be piriformis. That may be, so it's different for different people, and it can be different based off of your activity. Yeah. But people tend to just kind of like lengthen the glute med. So let's say we did that, right? We have lengthen the IT band. I misspoke there. Well, let's say we did that. So say we have no glute med and we stretch out the IT band. Well, what support do we have for our body while we're running? Mm-hmm. We don't have anything now. Yeah, because
it's
actually made it worse. Right.
It's giving stability where something else is weak, basically.
Right. Well, it's overworking, right? Yeah. It's doing its job plus the glute med's job. Mm-hmm. And so what happens is it gets tight, it gets tired. It's like, look, I'm done. Like, get someone else to do the job.
Totally.
So if you don't, so that's why, people say, oh, stretching is great, but strengthen first. Mm-hmm. And I don't mean like, in your day, I mean in your phases of therapy, strengthen first, because if you really focus on that glute med strength and the neuroplasticity and the connection with the brain, and then translate that to running, and you can really feel that glute med activate while you're running, which is kind of hard, but super important, then the IT band barely even have to stretch it because it's not tight.
Right. And I feel like that's one of the things you and I talked about in terms of the chronic knee pain too, because it's like, I think that nurse practitioners get frustrated for patients' behalf because they're in so much pain chronically for so long. And it's kind of hard to tell that to a person with chronic knee pain, go to physical therapy, it's going to help you, without being really comfortable talking about why. So I think that's like one of the reasons I'm so grateful you're talking about all this, because I think that even if our job as nurse practitioners is not to identify glute medius, right? Like, we can still understand how this whole thing works, so that when we refer a patient, hey, you have chronic knee pain, physical therapy is actually really going to help you. because it's building up the muscles that are supporting the joint so that the joint isn't doing all the work in a similar way, right? If I'm saying that right, like similarly to the IT band, the IT band is overworking, your knee, physical joint is overworking. So when you do physical therapy, maybe it's uncomfortable because you're strengthening muscles, but eventually all of your muscles in your thigh and your hip and all of that are going to alleviate that pressure, which ultimately in the long run is going to be helpful. Like you said, like it's not like you have to go to physical therapy forever. You learn and you understand what you need to do. And then if you get new pains in any place, you can see PT again, right?
So from a PT's perspective, that would be amazing if that was explained that way to a patient, because sometimes what happens is let's take knee OA, for example, right? So they have this chronic knee pain and then they come in for an x-ray. That's kind of the standard protocol and in the orthopedic world. So they get their x-ray and it has osteoarthritis and they say, well, what is arthritis, right? And then the practitioner explains, well, it's degeneration of the joint. They hear the word degeneration, which is breaking down, which is damage, which is irreversible. And all of those words, kind of what we were talking about before, they create fear and they create loss of hope because they're like, well, what can I do about that? I have to get the surgery, right? So but we know that people who have arthritis, there are people that don't have pain. Right. So we know that if we x-rayed a bunch of asymptomatic people, there are many things that are still positive, quote unquote, in their x-ray. Right. So whether it's a degenerative disc disease or it's, more like that degenerative osteoarthritis, that doesn't necessarily mean that person has pain.
Yeah.
So where the pain really comes in, it's physics. It's the forces that are being put on the joint because the muscles around it are not supporting it. Yeah. So if pain was explained like that from day one, from the first person that patient had interaction with, is like, look, pain just means that there's one area of your body absorbing more force than another. Very simply put. Yeah. And PT is that person who will teach you how to distribute those forces differently.
Yeah. Yeah. And I think it's so holistic and it's so, like, for just as another example, like I love giving examples for NPs, but like I've had neck pain and what we've been doing together, you and me, is rotator cuff. It's like, right? We're doing my shoulder and my back, because what's happening is that my trapezius, my like upper traps, are doing all the work because of my baby little back muscles that aren't doing what they're supposed to, right? But for me, I'm like, oh, I just have neck pain. Maybe I'll just stretch where it's really tight. It's like, no, actually, you're going to build up the other muscles so that muscle will relax by itself. And then my neck pain's better, right? So speaking 100%. Of imaging,
and that goes along with that, like that's your chronic tightness there, right? Yes. So what did you want to naturally do? You want to stretch it out. Now, is that bad? No, it's not. It feels good. It's great, but that's not the solution, right? That solution was really providing more support so that the upper trap didn't have to do everything.
Right. Work so hard. Absolutely.
Yeah, it's tired. Give it a break.
I know. It's such a good helper. With imaging, though, one of the questions that we got was about what imaging, like, so if somebody is going to refer, so say somebody has a patient in front of them, chronic knee pain, and it's the first time they're seeing a provider, say like, oh, I was diagnosed a long time ago. My first thought is like, you need to do physical therapy first. And like, by the way, for people who are watching, I hope this is getting a bigger, clearer picture for you, because I have to sell people on physical therapy, not for my benefit, not for financial gain selling, but for them to buy into why physical therapy is so important. So hopefully that is meeting here. But having that conversation with the patient, I feel very confident saying to them, physical therapy will be helpful for you. You're going to go in for a physical therapy evaluation, and you're going to set up a plan going forward of weekly or twice a week for a set amount of time, weeks or months, and they can give you an estimate of how long it's going to be. And that is going to ultimately help you. So that's my spiel, if you have any addendums for that. But I think the other part of it is the question that people have is, do they need imaging first? Like, so is that like how you would, before a patient gets to you, what do you wish they kind of knew and did in the context of how to explain it, and then also in imaging?
Yeah, so I mean, of course, everyone's a little bit different, but if there are red flags, imaging is important, right? So,
which is diagnosis dependent, right? Like, so saddle anesthesia or
Or why are they there? Was there trauma? Was there
Right.
a fall? Was it a car accident? Things like that. They need to be imaged, right? Because we don't want to be doing anything with a fracture. That's kind of number
Right.
one.
Right.
Anything else outside of a fracture, it could be, you're not really going to see in an x-ray anyways.
Mm-hmm.
Right. So we don't even generally have any of that information.
Mm-hmm.
And knowing that we don't treat based off of diagnosis, we treat based off of impairment. And just to clarify, what is an impairment? It's the thing that the patient can't do.
Mm-hmm.
So did they lose range of motion? Did they lose joint mobility? Did they lose strength? Pain, is this an impairment? Fear of movement, is an impairment? That's what we treat. So really, imaging isn't necessary. Now, there are times where we want images because we're stumped, right? We're kind of just like, maybe if we could, like a glute med tear, I would say that's a very, very underdiagnosed, overlooked diagnosis. You hear hip bursitis a lot, you hear low back pain a lot, but we talked about, how important that glute med is to support the back, support the hip, support the knee even. And a lot of times, especially in folks who are a little bit older, it's torn.
Oh, I think I had a family member with that actually. Yeah. That sounds familiar.
Yeah.
Yeah.
And that's one thing I always want like an image for, because it's such a frustrating diagnosis, because you go back and forth a lot. You're like, is this coming from the back? Is this coming from the hip? Because without the glute med, it's kind of coming from both, right? Because it really needs that support. But that's not something we expect a patient to have coming in. We don't mind that they don't have that. It doesn't really affect anything. The only time we really want imaging is if we're stumped. And the best way to do that is just to have, if we could have open communication with the nurse practitioner or the doctor or the orthopedic, whoever was the referring provider for the patient. If we could just have open communication and send you guys an email. I mean, sometimes emails are really hard to find or really hard to obtain. And so if we could send you an email, A, giving you a patient update status, right? And B, maybe like opening that door for communication, saying like, hey, this isn't, what we're doing isn't working. What's maybe they do need an injection because pain is such a barrier. Maybe they really, maybe they do need an image. These things aren't unnecessary, but sometimes they're overprescribed.
Yeah. And I was going to say, in my own personal practice, like I usually tell patients, aside from those like red flags, like diagnosis dependent red flags and like trauma and acute injuries, just to like clarify for new nurse practitioners, those are what we're talking about. But also like, if I've cleared those, I say it's always worth it to see a physical therapist, because in my experience, they always tell me I can't work with this patient. They need an MRI or they should see orthopedics next. Like they will let me know, or they'll be like, you know what, they're in too much pain to participate. Can you give them some pain medication or something like that? Like usually, is that typically your experience as well? Like I feel like I can trust physical therapists with that. I mean, I've worked with better and not as stellar ones, but the ones that I really trust, like I'm like, I set it up for the patient of what to expect, and then they let me know how it's going.
Yeah, I mean, the better communication you can have with your physical therapist, the more comfortable you're going to feel sending your patient to one, right? If you have that relationship with a PT, doesn't have to be just one, can be a whole network of them, to choose from. And then, you also get kind of a feel for people's styles of how they do things. And you might be able to say, oh yeah, this patient, I kind of recommend them to that person because they kind of push you a little bit more. They're going to get you back to, playing soccer. And this patient, they're really good when people are scared and things like that. So I think the biggest thing is, try to create that relationship with the PT, because I tell you right now, like we want it.
Yeah. I so appreciate you saying that, because I feel like I say all the time, cold calling for specialists of any kind, for nurse practitioners to develop relationships with the people that they refer to, because they want it. And I appreciate you saying that, because it's like, you're trying to do your job. And like, sometimes they feel like they're bothering, and it's like, no, you're actually helping make sure that the appropriate patients are going to the right place, right? Yeah. Like, we don't want to send you things that you don't have the ability to see, or because they are not appropriate, right?
Yeah.
So
there are definitely things that like are outside of people's skill sets. Not every patient sees pelvic floor. Not every physical therapist sees patients that have pelvic floor dysfunction or TMJ or a hand issue.
Mhm.
So absolutely, knowing what their specialties are, and if you don't ask, like,
Yeah.
we would love to talk to you.
Yeah, they're not scary. They're
No,
not
that's
scary. They
scary.
get so scared. I'm looking at the questions that were submitted. So are there any red flags that you see that get missed by a provider that referred them? Or is it not too
So
bad?
I worked, trying to think which, probably like when I worked in like Somerville and Cambridge and things like that. And I can't tell you why this location was like this more so than others. I'm not really sure. But there's a high percentage of patients that are hypermobile.
Mm.
And that is a diagnosis, I feel like that's really underdiagnosed unless someone's coming from Children's Hospital, where they're kind of getting it as a kid, and there's times where I've diagnosed people with EDS, and I'm like,
Ehlers-Danlos syndrome, you mean?
yeah, Ehlers-Danlos syndrome, exactly. And I'm like, you really got to talk to your doctor about this, or, there's a specialist in Boston that I'll send them to, or I don't have a percentage per se, but I would honestly probably guess maybe more than 50% of my patients have this.
Wow.
And so, like, what is hypermobility, right? So the way we diagnose it, or kind of can say that someone has it or not, is just based off of the Beighton scale. And if you're not familiar with that, it's just 9 tests. So the first thing is your hands. So can you reach like your thumb down to your wrist?
No.
No, I can't either. But you'll see, like, some, this is like the old word would have been like double jointed, right?
Mm-hmm.
And so you'll see people like they can do that. I can do some of them. So like the pinky is next. So if you can bend your pinky back beyond 90 degrees. So you're at like 88 degrees over there.
Oh.
You're just about there, but you can see how that's obviously more than 90, right?
Yeah.
Or this one doesn't go as far, but still more than 90. So it's 1, 2, 3, 4. Okay, so each side of the body counts as a different number. The next thing is elbow hyperextension. I don't really have that, but you're looking for more than 10 degrees of hyperextension, and you really want to measure that passively, because sometimes actively they'll just kind of stop here, and so you really want to get that full hyperextension. So that's 5, 6. And then the knees, so you're looking at either standing or supine hyperextension of the knees, same thing, that 10 degrees. And then if they can or could as a child, like palm the ground with their knees straight, so like bending forward, reaching their palms on the ground, not their fingertips, but it has to be like a flat palm, and their knees have to stay straight. So if you have more than 4 of those be positive tests, it's considered classified as hypermobile. And that can really change diagnosis. So, people who are hypermobile, there's been strong links with anxiety even, right? So these people are going to have possibly a higher fear of movement. There's been strong links with lack of proprioception. So one of the things that's like another criteria that fits into this is, do you trip a lot? Are you clumsy? Do you drop things? And so from your standpoint, you might think of those questions as like a neurological concern, right? Like they're developing some sort of neurological disease, and you're like, oh, that's not good. But what if they've just been like that their whole life? Like the person, and I'm kind of like, I clip my shoulder like on doorways a lot. Like, and the thing is that you don't know where you are in space.
Oh, that's so interesting. I feel like I sort of meet criteria for this. Not really.
I think you do, actually. I think we tested that. Yeah.
I think my neck is a little hypermobile. I'm definitely clumsy. That's so interesting. So you probably are just treating them a little differently, just being more mindful of their therapy.
For them, 100%. For them, it's posture. It's posture, because so let's say they stand with that genu recurvatum in their knees, that hyperextension, right? What's going to happen to their low back? It's going to increase the lumbar lordosis, right? So I've had people come in, 10 plus years of back pain. Watch them stand, they hyperextend their knees, they have that increased lordosis. I say, soften your knees. I tape them in a softened knee position so they can't move. And they come in there like, their back pain's gone.
Wow. So
right?
cool.
So it's such an easy fix, and I just feel like that's got to be on people's radars a little bit more to have that like hypermobility scan, because
Yeah.
it does lead to a lot of different things. And I mean, if someone has like Ehlers-Danlos syndrome, or they could have POTS syndrome, or even like Marfan's, you know, they could have cardiac issues.
Right.
There's other systemic things that could be going on as well that need to get ruled in and out. So.
Totally. That's so interesting. One of the questions was about being able to read physical therapy notes. And for me, I glaze over and I'm just like, it's going well. I signed it and it's in their drawer. Like, I don't really know how to read physical therapy notes. I don't know why. Like, I can't even think of the examples. I just remember reading it and it looks very different from the way that we write our notes. And so I just was like, therapy's going well, I think. Just like maybe bad.
Yeah, no, we know what happens. You know, generally we only sign notes for Medicare. We send notes out to be signed for Medicare patients anyways, just because that's an insurance requirement. But there's a Massachusetts requirement that every 30 days a physical therapist has to do a progress note. And most EMRs will just send that to the referring provider, like in a fax or an email or whatever. So that's why you get our notes a lot of the time.
Oh, I was wondering. I was like, I wrote a prescription. I don't know why.
Like, why are you talking to me? Go away.
No, I like hearing it, but I just was like, I didn't understand the signature part. I thought I was being an inconvenience, that I wasn't sending the right stuff in the first place, but I could have just asked.
No, yeah. So with Medicare, it has to be signed. The initial evaluation, every progress note, which is every 30 days, and the discharge note has to be signed, or the insurance company doesn't reimburse us. Which that's a whole different soapbox. But there's no other insurance company that does require that. But Massachusetts law does require that we send the progress note. Now, that progress note does not have to be signed if it's not Medicare, but we do have to send it to you.
I see. And I like hearing it. I just don't know how to interpret it.
Yeah. So basically, it's subjective is the first part, right? So it's like, how does the patient feel things are going? So that's good or bad, you know. The objective stuff I think would be the hardest, because it's all just numbers, and you're like, what you don't know what the normative value is. So it's like, oh, they have, you know, 55 degrees of flexion. It's like, well, what are they supposed to have? You know, that doesn't tell me anything. So I can definitely understand that. I think if you read any part of it, read the assessment, because that should be written in like plain English. That's just kind of like, you know, patient presents with this, they could do this, they now can do this, they're still working on this, they would still benefit from PT, is generally like the formula for that aspect.
Yeah, and I feel like too, when I've seen them, and I do appreciate seeing them, like the part that I understand, but it's usually like, what are the goals? And it's like to be pain free by the, like, there's usually some sort of like metric goal of like, they want to be like without pain during certain activities, like that kind of thing. Yeah. But I usually just say like, do you need more physical therapy? I'll write more. Just let me know. Do your thing. You do you. I think one of the other questions that really came up a lot was about, I think the main challenge that I see in primary care, aside from like kind of like convincing patients, and again, I say that in quotes because I'm not coming from a nefarious place. I'm coming from like a connecting them to understanding what exactly the benefit is, right? Like it's not like I have no agenda aside from to help them, right? But sometimes you have to get people's buy-in and you have to explain things.
100%.
Like, what are their objections? And usually the main two objections are, main three, is this going to help me? How does this help me, right? And so that's what the purpose of our talking is, so that we can fully understand. I mean, we can't fully understand it in like a half an hour, but you can better understand what the process is and how it and actually believe with gusto that is going to help, right? And then number 2 and 3 are about cost and about time. And it's either cost because they don't have insurance, or their insurance in Massachusetts, there's a plan that only covers 6 visits per year for any condition. I don't know if that's been updated, but there's some other ones that will cover, like for me personally, I had a back injury being covered for, I think 60 days only. And then the other part of it is copays, right? So like, is their copay too high? Those are the main like objections. And so when it comes to like selling a patient on it, it's kind of like addressing those things. But do you have any thoughts about that? Because I know that we were both frustrated with the state of insurance access and physical therapy access. So what are your thoughts about that?
Yeah, it's hard. I disagree with how insurances deal with that, because I mean, every insurance is different, of course. I know it has since changed, but there was an insurance that said 30 days, actually. It's like you get 30 days to fix the condition, and it's per condition per lifetime.
Oh God, really?
So if you had an ICD-10 code of MeOA, right, you got 30 days in your entire life to fix it. Which is wild. It's wild. And so then they changed it to 60 days. And I think they've since changed it to 60 visits in a year, which is much better. 60 visits is a lot. Yeah. Generally, you should be seen for under 20. You know, it should be, if it's really straightforward, like an ankle sprain or things like that, 12 visits or so is like 2 to 3 months is really enough. Or if someone has, especially anything with like healing from a fracture, those are pretty straightforward. Post-op is generally going to be about 4 months. Unless it's ACL, it's going to be about 6 months.
Oh my gosh. I love hearing this because like from my perspective, like that is so disparate from insurance. And also it's nice to hear that, like, I think it's also important for us to know as nurse practitioners how to set patients up for success. Costs and stuff aside, but like even in that communication piece, like this is going, like when you and I first met with my back, you were like, ooh, 60 days is not that long. And in my perspective, I was like, oh, really?
Yeah.
It's going to take a long time, but that's nice to know. Like I knew about an ACL tear, but like I didn't know about post-op is 4 months, and that's helpful to know.
Yeah, usually like that 16-week, and this is again kind of categorizing, but if you look at pretty much any post-op rehabilitation protocol, around that 4-month mark, they're starting to do like sport activity, right? And some insurances don't even cover it if you're only working on sport activity. Sometimes that can be a little bit tricky you kind of have to be creative with how you write things. So it's just a conversation that you want to have with your patient too. Like sometimes I'll see people have like a $75 copay, and I'll be like, can you be here twice a week, or do you want to just do once a week, or do you want to do once every other week? It's our job to work with you to figure it out. Yeah. So if you only get 6 visits, but it's your job to know your benefit though, right? Yeah. So know your benefit, come in and kind of discuss the concerns that you have. Most PTs are going to try to see you twice a week, right? Because it takes that repetition to really build it. I think there's a study out there that says, it's a little vague, it says between like 300 and 600 repetitions are really needed to not learn a new skill, but just actually build that neuroplasticity of a muscle firing, right? So that's a lot. And then if it's in the beginning and you're not really getting that feedback often enough to know that you're firing it correctly, and then you're firing it incorrectly, and then you're kind of wasting your time. And so that's why we try to say twice a week, at least in the beginning. And then maybe once a week after you feel more comfortable and you're working on more of the strengthening aspect. Yeah. But we're very flexible in that. And if they're not, then you have to think about, do they want your fee or do they want to help you? So you got to be careful with that.
Yeah. And I definitely can attest to that in a personal level of like, when we started working together, I was really frustrated with how slow it felt for things to start working. And I felt that that was very reassuring to me, again, to pass this on to patients of like, my like dead muscles, my sleeping muscles took that much time just to wake up. And then you can start building strength, and then you start getting pain relief. But like having the initial, like, am I doing this right? Am I activating the right stuff? Twice a week early on was really helpful for that. But I mean, that's the thing that I'm saying to patients is like, I so appreciate that you have that paradigm, that perspective, so that we know counseling patients that if your PT is not saying that back to you, then that may not be a good fit, or have a conversation about that. But I think one of the things I say to my patients at the very least is like, can we please just go for an evaluation? And please tell me if I shouldn't be saying this to patients anymore, but I'm like, please just go for an evaluation. I don't know how long it's going to take. I don't know how many visits. And I know that you have a limited amount, but at the very least, let's have a conversation with them and figure something out. I mean, I think it's better than nothing is my perspective.
No, I think that's a great conversation. And actually, when you don't write on the prescription, the frequency is great because the patient will lock into that. So anything that's written on that prescription, you have to remember that's kind of like the notes you're sending home with the patient. So if it says right on there, like degenerative disc disease, that's what they see over and over and over. And then it says twice a week for 6 weeks. Okay, so now that patient comes in, and this is what we have to deal with. So we have to deal with the fact that it's degenerative, the fact that it's a disease, and the fact that it's not going to change. Okay, now we have to deal with the fact that it's set in stone that they have to be here twice a week, and this has to be fixed in 6 weeks. Okay, so it's a lot of things that I know you didn't even realize that just happens, but it's a lot of things we get set up for.
Yeah, that's not setting your relationship up for success, for the success of the patient.
Right. It definitely can have a detrimental effect. And what can happen is some of those visits can be wasted, essentially, in working on that trust, just to get the patient to understand that, like, this is something that we can work on. It's not going to take 6 weeks, and so on and so forth. Sometimes that can actually be 3 of their visits, just getting them on board, right? Yes. Now, imagine if they came in on board, or came in, maybe not on board, because that's a very difficult task sometimes, but at least came in where we're all on the same page, so they don't get this like conflicting advice, because anything conflicting creates confusion, and anything that creates confusion creates distrust.
Yeah.
And that's the last thing we want to do with someone that we're trying to get to open up to us, right? So kind of go back to that psychotherapy analogy. The patient has to trust us. They have to, I mean, we do have their best interest at heart, and we do want to get them better. But sometimes when things are painful, or things are hard, or they are frustrating, or they are not as clear cut as they feel that they should be, there's already so much working against us, because it's not a cookie cutter thing. It's really hard to start at that baseline.
Absolutely. And that's why I feel like it's so important for us to be well-versed in this, at least well-versed in the process, and trust in the process ourselves as providers. So if we can set the patients up for success, they're already amped and ready to work with you. I mean, not necessarily amped, but like they're way more likely. They're way more likely to already be bought into the situation. It's like, I have a physical therapist that I trust. I'm going to send you to her, and you know, just like setting them up so that they can just start with a very small amount of trust building, hopefully with you, and keep going, right? Especially if they have limited benefits and limited time, right? Because no one has time. But also that 100%. There are telemedicine options, I think, depending on your state and depending on your practice. I know that our Massachusetts has that as well, and it works for some of my patients with their insurance. And then you and I have worked in telemedicine too. So I try to, you have to figure out what's available in your area, hopefully like through your colleagues and your supervisor, and just cold calling. I love cold calling and just connecting with people, so that you know what the resources are to help them. Because like it's a little bit more work on our end, but it depends on the clientele that you're working with. Like sometimes we have to go that extra mile to help patients, you know, especially if there's language barriers and things like that. But if you know what the resources are, you can more confidently refer them along so they can get better. And then they'll report back how good it is and how you were right the whole time. And then then you'll say to them, tell all of your friends. That's literally what happens in my practice. They're like,
it sets you guys up too, right? Yeah. So I mean, like you set us up, and then it goes well, and it goes back to you, and it's like, hey, like that, you're awesome. Thanks for sending me to her. So it's really just a win-win for everyone, and most importantly for the patient. And just to touch on one thing you just said about telemedicine, a lot of people, you know, they think, I mean, PT is a hands-on thing, right? So we do provide that as well, but that's not the only thing. We talked earlier about, like, you know, there's a lot of compensatory patterns. There's a lot of ways to wake up muscles, and you can certainly do that through telemedicine. And it's so much better. I mean, in a perfect world, would you be in front of the person? Probably. But if there's any sort of restriction because of the commute or time, or you're not feeling well, or it's just, you know, maybe you're at home with 3 kids who are homeschooled, you know, there's a million different reasons that could be an option for you. But I definitely was skeptical about it in the beginning. I was like, how do I do that? And it works really well. It really does. So, you know, just encouraging that to be an option is huge, because I think people get a little kind of skeptical about it.
Totally. Well, thank you so much, Stephanie. Any last parting things you want to share?
I think one thing that I like to tell patients is that this injury is a blessing. And the reason is because after physical therapy, they are going to move better, they're going to be stronger, and they are not going to have those same compensatory patterns. So in the end, they should be better than what they were baseline.
Absolutely. And I honestly cannot agree more. I'm so grateful I have hated being injured, but I'm so grateful for like all the work we've done. And I'm going to try not to cry because I'm so grateful. So let's wrap it up there.
Well, thank you so much
for being here. Thank you so much.
Thank you.
I'm going to love this. So thank you.
Thanks. It was a really great time. I really appreciate it. Thank you.